Vamos em frente. Eu queria agradecer muito a presença e a pontualidade de todos vocês. E a gente segue agora falando dessa temática que nos move, a segurança do paciente. Como eu comentei no final da manhã, a gente vai iniciar a programação da tarde após esta merecida homenagem com mais um modelo, um exemplo internacional. E para tanto, nós gostaríamos de convidar ela que é diretora assistente de segurança do paciente do Instituto Armstrong, lá no Instituto e também no Hospital John Hopkins, para a palestra Segurança do Paciente. Muito bem-vinda, Melinda Sawyer. Lembrando que ao final teremos um espaço destinado a perguntas, ok?
Thank you. It's an honor to be here today, and I would like to thank my colleagues and the leaders from the Hospital Moinhos de Evento for inviting me here today to speak. It's a real honor. At Johns Hopkins Hospital and our health system, as well as in the Armstrong Institute, we have the opportunity to work with hospitals all over the world to help them drive performance and end preventable harm. And so we're going to talk about today the model that we use not only in our own hospital to improve performance, but the very model we've used to lead national and international projects. And so we're going to talk about the technical and adaptive skills that are necessary to lead preventable harm. And before I go on, I don't know about you, but I've been really energized from hearing all the speakers this morning. And I'm ready to go back to my hospital and keep the hard work going. Hold on. And so these are just the objectives that I'm going to try to cover today. And before I go on, I just always want to take a moment to recognize and remember why we're here and why I'm here. This is Josie King. She was an 18-month-old little girl who died at Johns Hopkins Hospital due to failures in teamwork, failures in communication, diagnostic delays. And we remember her because she's what's transformed our culture to one where we didn't talk about patient safety to one where patient safety is the center of everything we do. And so we never want to forget her, and we do all of our work in her honor. So as you know, there's a growing mandate to eliminate preventable harm and reach levels of quality and safety that are comparable to other highly reliable organizations like the nuclear power industry or the airline industry. These highly reliable organizations, they create a culture of safety through the commitment of safety across all levels of the entire organization. And so although it needs to start at the top, it has got to be filtered through and live in the individuals of everyone in the organization. If you're a nurse, if you're a physician, if you're a housekeeper, if you're a nutrition worker, everyone in the organization needs to understand what their role is to keep patients safe. And we know that highly reliable organizations engage in something called mindful organizing, which represents a very dynamic process that engages frontline staff in thinking and action. It relies on continuous real-time communication, and it results from bottom-up processes rather than top-down processes. And so when we go back to our organizations after this two-day event, and we're excited to get going with our quality and safety, one thing you have to remember is that so far in healthcare, we have not been all that great at eliminating preventable harm. We still know there's a lot of harm happening. And so I ask you, do you think that most projects in healthcare are successful or do they fail? Actually, most projects in healthcare fail. Some reports that up to 80% of projects do not achieve the results that they're trying to achieve, nor are they able to sustain them. And so we have to learn from those mistakes. I heard this morning that we have to create organizational learning, that we always have to be learning, not only from what goes really well, but what goes wrong. And learning from our projects that go wrong help us perform better in the future. And so one of the most common leadership mistakes is expecting technical solutions to solve adaptive problems. And the focus of my talk today is going to kind of differentiate these technical and adaptive problems so that we can have more successful projects moving forward. So this is an example of how poorly we're doing in healthcare in crossing and closing that quality gap. This is a landmark RAND study. It's a little bit old, but it shows that in the best of circumstances, we're able to deliver the evidence-based care about 70% of time to patients. And in the worst of circumstances, we're able to provide evidence-based care to every patient only about 10% of the time. And so I don't know if it was you or me or if it was my family, I would want this to be 100% for all these diseases. And we're not there yet as a healthcare delivery system. So when we look at some of the reasons and some of the root causes and some of the strategies to improve care, a systematic review in the literature tells us at the bottom here that, in fact, combined multifaceted interventions are the most successful and effective. And so when we're planning our interventions, we have to think about this and think about multifaceted interventions and not just one intervention. So this is the framework and the model that we use in the Armstrong Institute, not only at Johns Hopkins Hospital and across our health system, but in every large scaled up project we've ever done. So this is a combination of translating evidence into practice, which drives reducing preventable harm, coupled with an adaptive piece called the Comprehensive Unit-Based Safety Program. And in every single one of our projects we've ever done, whether it's our Michigan CLABSI work that was published in the New England Journal, or it was our national On the Cusp Stop BSI collaborative that we did across the United States, every single one of those collaboratives partnered this technical work of translating research into practice with this adaptive piece of changing culture and working through unit-level barriers. And so I'm going to spend a lot of my time differentiating these two so that we learn from those common leadership mistakes of not assuming that using a technical solution is going to solve an adaptive problem. So this is the translating research into practice model that we use for both small scale as well as large scale improvement. So it's really 4 main steps. You want to summarize the evidence. You want to identify local barriers to implementation, and you have to understand those unit processes that help get that work done. You need to measure performance and ensure all patients receive the evidence. We have to close that quality gap and make sure every patient gets the evidence every time they need it. And so I'm just going to spend a few minutes going through each of these pieces. And so when you're summarizing the evidence, you want to identify interventions associated with the improved outcomes. You want to select interventions with the largest benefits and the lowest barriers to use, and then convert those interventions into behaviors. And so that's really what we believe is a key step in this large-scale framework model, is making sure you're converting those interventions into behaviors. Because I don't know about you, but the central line associated bloodstream infection guidelines, they're about 50 pages. And that's just one type of harm in healthcare. I can't remember as a clinician what those 50 pages are, not to mention the ventilator-associated pneumonia guidelines and the surgical site infection guidelines and all the other guidelines I'm expected to know. But if we can identify the few most important ones for each of those and then convert them into the behaviors I'm expected to do as a clinician, and then remove barriers to make allowing me to do those, then I'm much more likely to do those for our patients because it's the right thing to do. And so the second step here is to identify local barriers. And we call that going to the Gemba or going to the work unit, because we have, you may have multiple ICUs or units in your hospital, and the processes of care are a bit different in each of those. And so you have to go back out to that local unit to figure out what's going to be hard about doing those behaviors that you expect those clinicians to do, and then working to overcome those local barriers. So let me give you an example of that. In Johns Hopkins, when we were trying to do the central line checklist early on in our work in 2001, we asked the providers, what is hard about doing full barrier precautions? And we went out and we watched providers trying to do this, and they had to go to 9 different places in our ICU just to get the equipment to do that behavior. And so we said, that's too difficult. Let's put it all into a kit, and let's make it easy for you to do. And so that's where the ideas of these kits came from, is let's remove all the barriers to make it hard. If you grab a kit, everything you need is in there, and then it's easy to do that particular behavior. And so that's the idea with this step, is really going out, we call it walking the process, working with the frontline clinicians and watching them and looking at how they're doing it and engaging them and finding out what is hard about this behavior. And then we also at this point want to make sure we're enlisting, really went back. All right, enlisting all the stakeholders to share their concerns. We want them to identify what they see as the potential gains, what they see as the potential losses associated with this implementation, so we can begin to sort through all those and uncover them so that we can address them. The next thing we want to do here is measure performance. We've heard about this all morning long, so this is not something new for you. We want to select the measures. We want to have a combination, ideally, of both outcome and process measures. And we want to develop and pilot test those measures. And then measure our baseline performance, so we know how we're performing before we ever change any care. And then we want to make sure in this last step that we ensure all patients receive the evidence each and every time, and be really clear that that's our expectation, and work with our teams to help them get there. And so we use what we call a 4 E's model to engage clinicians and get them to begin to do these behaviors. And so it's engaging them, educating them, executing on the intervention that you plan to execute, and then evaluating the progress, ongoing measurement around their performance, not only with their process measures, but with their outcome measures. And so these are, so these 4 E's, and then later I will talk about these 2 additional E's, but we have, in engage, you want to win over the hearts and minds of the clinicians. If you want them to change the behavior, you need to help state a case of why it's important for them to do that. Then you need to educate them. Then you need to execute your implementation plan, and then evaluate it. And that leadership is critical across all phases of this. Whether you're a senior leader or you're a local champion who's leading the work, you really need to be able to have leadership across all of these and have clear plans across all 4, or what will be 6 phases. And so as a leader, you need to remember that you have to tackle both those technical as well as those adaptive challenges. And so let me differentiate those for you. So a technical challenge is that when there is a knowledge to implement a solution, often it's a solution that involves a skill. So for example, with the central line, it's we want you to do full barrier precautions. That's a technical skill. We want you to do this thing. We have knowledge that it's effective, and we just have to figure out how to get people to do it. On the adaptive side, however, this can only be addressed through changes in people's priorities, beliefs, and habits. That's that culture piece, right? You have to engage people to change the culture of the organization so that you can be a change organization, and you have to always be engaging them to want to change and to improve care. And this is where it focuses on the unit and the organizational culture. So I always like to say adaptive work eats technical work for breakfast every day. If you don't get the adaptive piece right, you will not get this technical piece in. And so this is really, really important piece, to not forget this adaptive piece. And so when you're leading adaptive change, you have to do a few things, right? You have to clarify what hill you're going to climb and invite others to show you how to climb it. So whether your hill is CLABSIs, or VAP, or surgical site infections, or VTE, venous thromboembolism, or DVT, whatever your hill is that you want to engage your teams to do, you have to clarify that that's the hill you want to climb, but you have to invite everybody to help you figure out how you're going to climb it. And you have to communicate that need for change. You need to surface both the real and perceived losses. So let me give you another example of this. When we told our providers at Johns Hopkins that we were going to have a nurse complete a checklist on their behaviors during central line insertion, you would have thought that we were, stripping away all their power. They were really upset. They said, how can you ask a nurse to correct me in front of a patient, right? And that was a perceived loss of status for them, or a real loss of status for them. And so we had to surface that, and we had to work through it. And we had to say, I think we had to frame it and say, don't we all agree that these behaviors are critical to end infection in our patients? And we all agreed, okay, so you're human. Humans make mistakes. You're not going to remember every one of these steps every time, and wouldn't you like to have a nurse catch you and help you overcome that memory loss, you forgetting a step, so that you can ensure every patient gets this evidence each and every time because you said it's important. Okay, we'll do it. And so then we had to work with the nurses to say, okay, how do you call out a behavior that a provider just forgot without making it uncomfortable for the provider, right? And so we are very proactive. So when we're filling out the checklist, we say, oh, the next step, don't forget to, do full barrier precautions. And we prompt them, so it's not a correction, it's that we're helping them do each and every step. And it's very comfortable for everybody. But we had to surface those real or perceived losses, or those providers wouldn't have been engaged in the work at all. We had to create a containing vessel to communicate. We had to figure out how we were going to communicate. We had to communicate often, communicate across all levels of the organization. And if we didn't communicate, it was likely that gossip and made up stories about what our intentions were would have prevailed. But because we clearly communicated often, none of that was able to rise up and the next thing you want to think about is tuning into what we call WIFM. It's what's in it for me. So as a provider or a nurse, if you're asking me to do this extra step, what's in it for me? What's the benefit? Is it going to benefit my patients? Is it going to make it more efficient for me? Or is it going to make it less efficient for me? And if it's going to make it less efficient, what do I need? Why should I do this? And so we really need to tune into why we're asking them to change. And then valuing the dissenter. I'm sure none of you have this problem, but at our hospital, we have people all the time, they're like, I'm not gonna do that. That's not what I wanna do. I'm sure you guys don't have that here. No. But I value those dissenters. They have wisdom, and I need to tap into that wisdom and figure out what it is that they're telling me that I'm maybe not seeing. It's in my blind spot, and I invite them to help me lead the project. Because I value what their opinion is. And then finally, you'll have to monitor for organizational pressures. If there's a lot of other pressures coming from somewhere else in the organization, maybe now's not the time to do this intervention, and we need to have a candid discussion about that. And usually that we include the leadership in that discussion so we can all have really strong ideas about what's the most important thing to do. And so I heard this morning from lots of folks that we need to create opportunities to learn from our mistakes. And so this is a mistake. This is one of my failures in differentiating technical and adaptive challenges in a project I was working on. So I was working and put in charge of leading a catheter-associated urinary tract infection initiative at my hospital. And this is where I failed to differentiate a technical versus adaptive challenge. So I'll just tell you right now, this is, there's one difference between these two pictures. And for those of you in the ICUs, you may know this. This is a urometer, right? And this one doesn't have a urometer on it. And so we were trying to figure out why in our intensive care units, the nurses were breaking open the sterile line of the urinary tract, the urinary bag, the Foley catheter, and it was because the patients were coming up from the emergency department with this, and the ICUs needed a urometer. And so I addressed it, I tackled this as a very technical problem. Well, let's just get the kits down into the ED. I sent an infection control practitioner down to get that done, and 6 months later, we still didn't have it done. And it's because I failed to differentiate that the reason why the ED didn't want to put this wasn't a technical problem, it was an adaptive problem. They didn't see any value in this. They didn't want to change their culture. The reason is that they were being held accountable to a very narrow budget. And by adding this device, they were going to go over budget. And they said, nope, we're not changing that. That's not important to us. We don't see a problem with the care we're providing, so we're not changing. And so it took a little bit of more work, some leadership engagement, and we were able to tackle that adaptive challenge and get these urometers down to the ED so that the ICUs didn't have to break that seal. But I like to talk about my own failures, and this is just a classic one of where I failed to differentiate these two technical and adaptive challenges. And so when you're thinking about these leaderships, on your projects, right, you have to think about 3 different key types of leaders. You have your strategic leaders, right? They're going to design for the future. They're the ones that see the whole systems. They have the big ideas. You have your operational leaders. I'm an operational leader. I see how to execute on that intervention, how to get the work done. And you have your networking leaders. So for those extroverts in the group, right, they're going to make all the connections and connect the different departments. And I need to have all 3 of these people on my team because that's how we're going to be most effective. We have to have all of these. It's really important. And I need to know where I'm strong and where I'm weak and where you're strong and you're weak so that we can make sure we're getting everything we need. And all 3 of these, like I said, are really important for successful change. So competencies for leading change, right? So leaders, whether you're any of those 3 I talked about, you need to be sensitive to the influence of the systems, so supporting a just culture. You need to design for the future, develop a vision for both the technical and the adaptive challenges and change. You can identify causes of variation and react appropriately, and develop relationships. And finally, you need to learn from defects, and I'm going to go into that more in detail later. And you have to really lead at different stages of each of the projects. So when you're asking clinicians to change their behavior, you have to ask them to stop doing a behavior they've been doing for potentially a long time. And they have to let go of that old process and to that old way of thinking. And a lot of people feel a sense of loss at this time. You have to support them through that loss. You need to provide them with the evidence, new evidence potentially, about why what we know now requires change. You have to then manage and support them through that neutral zone where they're transitioning and they're trying to get down those new behaviors, right? So these new behaviors are trying to get them down. And if you don't manage well at this stage, you'll see clinicians start doing workarounds, right? So you didn't address the things that came up during implementation, and they'll start to do workarounds because they weren't supported in this neutral zone. And then finally, there's this new beginnings where stakeholders become committed to the new vision that you have. They see the benefits of the change they're engaged in, and it becomes the new status quo. And you have to celebrate those wins and really support them and recognize their efforts to do that, engage in that change. And then finally, I mentioned this earlier, but there are these last 2 E's. So once you achieve the goal, then you have to figure out how you're going to sustain that over time. And that's what we call endure. So how are you going to develop your policies, your procedures, you're training new people who come onto the unit or to the new hospital? And how are you going to how are you going to have ongoing audit process so you can monitor those processes as well as those outcomes? Because if you stop auditing it in the long term, is it going to, when you focus on another initiative, those outcomes going to go back, get worse again? And so that's the risk. And then finally, you have to expand to the rest of the hospital. So if this was a local initiative or a hospital initiative, how are you going to expand it to other hospitals or to other units? And you have to be able to allow those units to adapt to different circumstances that are particular in their unit or in their hospital. So it might look a little different, but you have to allow for that variation, what we call mindful variation, not mindless variation. And then finally, I've kind of gone over this technical piece, and I've talked about some of the adaptive challenges. Now I'm going to go over to this adaptive piece called the Comprehensive Unit-Based Safety Program. We call it CUSP. And so CUSP, some of the pre-work you have to engage in is measuring clinician and staff perceptions of safety culture. So there's several valid survey tools out there. There's the Safety Attitudes Questionnaire. There's the Hospital Survey for Patient Safety. They have all different variations of that. So they have one for ICUs, one for ambulatory care, one for surgical centers, etc. So at our organization, we measure culture every 24 months. And we have 5 different tools we use to allow for that variation and that survey to make sense to the clinicians who are filling it out for a particular area. And we just wrapped ours up in February, and we had 16,000 employees take the survey. And that was about a 70% response rate for our health system. So in CUSP, we implement these CUSP teams in all of our clinical areas. So at Johns Hopkins Hospital, we have 74 CUSP teams. In Johns Hopkins Health System, we have 156 CUSP teams. And that's, if you think about that, that means there's 156 teams out there every month working on their local safety issues. And I don't know about you, but as the director of patient safety in my hospital, patient safety doesn't live in my office, it lives with every individual. And these CUSP teams allow that process to occur, where everybody in those units are engaged in safety culture, in safety work, and they're working to identify their defects and then learn from initially one defect per quarter, but I'll talk about how much more efficient they are at this now. But we'll go through each of these 5 steps. And so, why is this important, right? And so we've talked about it before, but in the United States, we have 44,000, 98,000 people die. That's, from to err is human. But a more recent study has shown that preventable harm is the 3rd leading cause of death in the United States. Up to 3 in 10 patients suffer preventable harm, and 6 in 10 patients report that they were not respected or heard. And in our hospital, we consider that harm when someone is disrespected. In addition, 1/3 of all of our healthcare spending is squandered on therapies that don't improve the patient's medical condition, which equals nearly $1 trillion in our US healthcare system. That's about $9,000 per US household is wasted on unnecessary medical conditions or spending. And why do these errors happen? Why is this occurring? Well, we know that every system is perfectly designed to get the results that it gets. So if it's a poorly designed system, we should expect poor results. If it's a better designed system, we should expect better results. And we have to acknowledge that people are fallible. All people, they're all going to make mistakes, and we have to allow our systems to account for those human fallibilities. We must view the delivery of healthcare as a science instead of an art, and we need to engineer systems to catch defects before they reach our patients. And that's what our CUSP teams are working on. They're working on doing these very things. And so when we ask our CUSP teams to start their work, we train them in what we call the science of safety. And it's around these 3 basic principles. First, we need to standardize our care when it makes sense to standardize. We need to create independent checks, particularly for the ones that are involve human processes. And then we need to learn from our mistakes. And we need to recognize that these principles not only apply to our technical work, but our adaptive work, so our teamwork and our communication. So why is it that safety culture matters? We know that high reliability organizations engage in safety, improving their safety culture, but what is it linked to in healthcare? Well, we know that poor safety culture is related to worse patient care experiences. We know that it's related to worse infection rates and sepsis. We know that it leads to worse post-op hemorrhage and respiratory failure or puncture or laceration, as well as treatment errors. We also know that there's clinician outcomes that are worse when we have a low safety culture. And we know there's worse incident reporting and more burnout and turnover among staff when we have low safety culture. So there are not only improvements to our patient outcomes, but also to our financial and operational outcomes of an organization. So we also know from the work that we've done that safety culture influences the effectiveness of interventions. So if you put in CUSP into a unit and improve safety culture, then you bring in lots of improvement work like CLABSI or CALDI or ventilator-associated pneumonia. That improvement work will be more effective than in units with low safety culture. And then it can also change through an intervention. So we also know when we couple CUSP with central line-associated bloodstream infection work, that culture also improves in and of itself. And we know that the best evidence so far for culture interventions are that they use a multiple component intervention. So there's 3 main interventions based on a systematic review in healthcare that are known to improve safety culture. 1 is executive walk-rounds, 2 is team steps, and 3 is CUSP, the Comprehensive Unit-Based Safety Program. So those are the 3 documented evaluated interventions in healthcare to improve safety culture. So why do we focus on CUSP, right? Because we believe very deeply that when we do things with clinicians rather than to clinicians, and when we allow them to learn locally and spread broadly, that our interventions will be better adopted and more effective. And so that's what CUSP does. It improves safety culture through local ownership of patient safety and partnerships with leadership. And it's just not in inpatient units anymore. We now have CUSP teams in ambulatory. We have over 35 ambulatory CUSP teams. We have CUSP teams in our transfusion lab, in our admitting office. Wherever there's any sort of harm that's at risk to happen, we have put CUSP teams there and they have tackled those harms. And believe me, you would much rather have a local admitting office tackling their safety problems than someone from outside their office who doesn't understand their processes. Again, it's about doing things with the clinicians and not to those clinicians. And so again, I'll just reiterate, CUSP is these 5 steps. First, you want to educate everybody in your local area on the science of safety and those 3 principles. You want to then identify defects, and there's lots of ways we can identify defects, right? There's looking at your error reports. You could look at your infection control rates. You can look at your sentinel events in that area. You could also ask staff. So every 6 months, we ask all our staff, how's the next patient going to be harmed, and what can we do to prevent that harm? And there's a lot of wisdom there. And we then take those risks, and we use our CUSP teams to drive performance on those. Then we want to partner our CUSP teams with a senior executive. And the senior executive isn't there to lead the CUSP meeting or lead the work. They're there to help remove barriers. And so if a CUSP team's working on a particular issue, they may encounter political barriers. They may encounter financial barriers. And that CUSP executive is there to help them remove all those barriers when it's necessary. Then they take the defects they identified in step 2, and then they learn from those defects in step 4. And we really work hard on having high-level risk mitigation strategies rather than low-level risk mitigation strategies. And I'm going to go over that hierarchy that we use and hold ourselves accountable for in a few minutes. And then the 5th step in CUSP is to improve our teamwork and communication. The reason is, teamwork and communication is one of the top root causes of sentinel events. And if we can tackle those teamwork and communication errors and always be focused on that, then we can begin to kind of overcome those root causes and keep our patients safe. And so when we're trying to learn from our defects, this is our risk mitigation strategies, or what we call our error proofing strategies, that we hold our teams accountable to. So first, when you have an error happen, we have 2 different paths we can take. We can try to prevent the error from ever happening again, and then there's several things we could do. We could eliminate a particular step that was error prone, we can replace it, we can prevent it, or we can facilitate it. I'm going to give you examples of all of these. Or if in some cases we can't eliminate an error, and so we have to reduce the harm associated with the error. And so we can try to detect it earlier in the process before it reaches the patient, or we can mitigate the harm that happens if it does reach the patient. So I'll go through many of these steps. All right, and then what we do is we tell our CUSP teams, and we tell all of our teams, I want you to start up here. Try to eliminate the harm. And then if you can't do that, then try to replace it. And if you can't do that, then try to prevent it. And if you can't do that, try to facilitate it. And then, and only then, do we go down to detect and mitigate. And so we start with the strongest and go to the weakest. We don't start down here. And we find many of our local teams just want to start down here because they don't have the rigor to start up here. They don't have the knowledge of this model. But that's part of our role, is to help them understand where their interventions are and then try to force them to go higher. So let me walk you through an example of each of these. Some of these are healthcare related, some of these are not healthcare related, but I think it makes it easy to understand. So for a very long time, there was a high risk of car accidents in tunnels because your car headlights people forgot to turn their car headlights on. And so the car industry, what did they do? they said, well, we're going to try to eliminate the need for the human to turn the car headlights on, right? And so most people now have automatic headlights. When you go into a tunnel, they turn on automatically, or when it's dark out, they turn on automatically. And you don't ever you've eliminated the human step of needing to remember to turn on your car headlights. So really effective at elimination strategy. And the auto industry actually really does a good job on these risk mitigation strategies, and we have a lot to learn from them. Here's a healthcare example of replace, right? So you take a very high error-prone step and you replace it with a more reliable step. And so, many of us who are a little older remember doing these calculations, right? Drip counts, remember counting the drip rates? Yes, yep. And so this was very error-prone. Nurses made mistakes a lot, not only in the math calculations, but in counting the drip rates. Your patient's arm could move a little bit, and then the drip would go in faster. And so we replaced this very error-prone step with a more reliable step by having smart infusion pumps. Now, do smart infusion pumps eliminate all medication errors? No, right? They're still error-prone, and so that's why this isn't an elimination strategy, it's a replacement strategy. And so we can often find more reliable steps. We took the human out of it, and we put in somewhat computing. Now, the errors happen when humans make mistakes in inputting the calculations, but it's a more reliable step in general. Then we have preventing, right? So this is where you can use, all of us have electronics, and there's like certain cords that can go into certain pieces. And so healthcare has done this, right? So an example is in the air versus the oxygen adapters in our room. So if you see this, there's a little prong at 12 o'clock and 4 o'clock, and the oxygen valve does not have that. So you can't put this whole piece into an air because it doesn't have the pins at the right on the right part of the clock. Here's a facilitate, right? So nobody probably here, I don't know that anybody here has probably ever seen this. We have these in a couple states in the United States. So a lot of accidents were happening because people tailgate. And when they tailgate and someone stops in front of you, you're at risk to hit the person behind hits the person in front. And so there's some rule, and I can't even remember it, and it's something around, you should stay 10 feet for every mile an hour. I don't know what the rule is. That could be wrong. But I can't remember it. So if I can't even remember it, how can I adhere to a safe distance? And so in some states in the United States, they say they're facilitating you keeping a safe distance. So they say keep 2 minimum dots apart. So if the car in front of me is 2 dots away, it's facilitating me doing the right thing. So does that mean it has eliminated me tailgating? Absolutely not, right? I can still tailgate. It's just making it easier for me to do the right thing rather than the wrong thing. So in healthcare, these are 3 examples we use at Johns Hopkins, right? So there's this thing called Braslow's tape where you measure a child, and however long they are, it's color-coded, and then you pull out the emergency airway equipment associated with that color, so you have the right equipment size for the child. In our ORs, when we need lots of transfusions, we have this facilitation tool which helps keep the blood that goes into the ORs at the right temperature because it's packed in the proper way. And this is another facilitation tool we use in our ORs, and this is to ensure patients get the right antibiotic prophylaxis before their OR cases. And it's based on different surgeries, and then it has weights, so if you're more obese versus less obese, it can account for that. And this, again, it's facilitating anesthesiologists doing the right antibiotic dosage. Does it prevent them from making a mistake? Absolutely not. It just facilitates them doing the right thing. And this is an example of how companies have gone from a weaker error mitigation strategy to a stronger one, right? So file cabinets. I don't know if you've ever read this label, but they used to just have a label on it that said, don't open 2 drawers at once, it could fall over on you. And I'm not sure anybody's ever seen that, but I've never paid attention to that. But now, file cabinets, you literally can't open 1 drawer and a second drawer, so it's prevention. They just won't let you do it. And so this is an example of how, even though they had a lower risk mitigation strategy early, they continued to work hard on it and get a stronger one. And we see that in healthcare a lot, where maybe today we can only do a weaker one, but in a year we're going to get to a stronger one, and that's our goal. All right, so I went over these preventing the errors. Now I'm going to go into reducing the harm from the error. And so these are examples of detecting when the error has occurred, right? So an ATM, you used to put your ATM card in, and then you'd get your money and you'd walk away and you'd leave your ATM card behind. And then it went to beeping to let you know, hey, you're about to leave your card behind. And now they've actually gone to prevention, because when you go to an ATM, you put your card in and it never leaves your hand. You slide it in and you put it right back in your pocket, and then you engage in all your ATM activities. So that's another actually example of how it went from detect to prevent. At the airport on my way down here yesterday, I didn't put my luggage in this, right? I don't know about you, but this is supposed to help you detect if your carry-on luggage is too big. And then this one is when you go to the mall shopping, and if they left the tag on the clothes, it alerts, or if you're stealing, one of the two, it alerts you that you're about to make a mistake. And then finally, mitigate, right? So let's say a mistake's going to happen and you can't figure out how to prevent it, but what you want to do is minimize the harm that comes to the patient and if it does happen. And so these are 3 examples of this. So has anyone ever seen this before? So someone was getting gas and they got distracted because they're humans and they make mistakes, and they drive off and the gas tank, the gas guzzle thing splits off. So before it used to send gas all over the gas station, but now it's like this quick release and no gas spills at all because so many people have done this. So usually there's some people in the room who's actually done this. Does anyone want to raise their hand and say they've done that? No one's admitting it. Okay, that's okay. I have 2 people on my patient safety staff who've done this before. This one here, right? The airbags doesn't prevent an accident from happening. It prevents you from getting hurt if, in fact, an accident happens. And so that's another example of a mitigation. And then finally, the most amazing button ever, the undo button. So when you accidentally hit delete, you can undo your accidental delete. I had this happen to me a couple times when I was writing up my dissertation recently. So again, now taking each of those and kind of translating them into healthcare interventions, right, showing you kind of the hierarchy. So if we put forcing functions or constraints into our electronic medical record, that's an eliminate. We can try to automate more of our work or put it in, computerize it. That can replace. We have standardization and protocols, checklists and double check systems. Checklists and double check systems are just facilitating you do the right thing. A central line checklist does not eliminate you forgetting a step. It's just helping you do that step. We have rules and policies. We have education. And then we have the weakest of all of them, which is just telling people an error happened and telling them to be more careful. That we never want to do, right? That's never sufficient to eliminating future harm. And so when we took these CUSP programs and implemented these strategies, these are some of the results we got from and its impact on safety culture. So when we did this across the state of Michigan with the Michigan CLABSI collaborative that we published on, you can see that before we rolled out CUSP, 84% of the teams in those ICUs felt like safety and teamwork needed to be improved. And after we implemented CUSP, only 20% of those same units felt like teamwork and safety needed to be improved. So huge improvements in safety culture and teamwork in these areas around CUSP, coupled with the technical intervention of central line associated bloodstream infections. These are examples of our own hospital and our very first CUSP teams. So in 2001, we rolled out CUSP to 2 of our surgical units. This was their culture scores before. The Weinberg intensive care unit improved to here 1 year after CUSP, and the surgical intensive care unit improved to here. And then another year later, they improved a little bit more, but the Weinberg unit went up here, and they've stayed up here since 2001. They have really high safety culture scores that they've been able to sustain for over 15 years. Really remarkable work. Also the same, this is where they were sitting with teamwork. And so since we've rolled out this work in Michigan, people said, okay, was Michigan, the CLABSI collaborative, we published that in the New England Journal, was it a one-off? Well, we've been doing this work in many other areas, and these are some of the results we've gotten since Michigan. So 66% reduction in catheter-associated bloodstream infections across 103 ICUs in Rhode Island, 71% reduction in ventilator-associated pneumonias across 112 units in Michigan again, 10% reduction in mortality in Michigan hospitals compared to the 350 hospitals in the surrounding states, 40% reduction in central line-associated bloodstream infections when we rolled it out across our entire country with over 1,000 hospitals participating. That led to about a $1.1 million annual savings in our healthcare system in the US. We saw a 33% reduction in surgical site infections in Michigan, and a significant improvements in safety, in teamwork, and nurse turnover. And just again, by doing these 5 steps and partnering them with that technical work, like CLABSI, CALDI, or whatever. So when you're starting a CUSP team, what are some tips or tricks we have, right? So we always say start in a few units and then spread. You're gonna learn a lot about how you're gonna need to adapt it locally in your hospital, and then spread it and learn from those to other hospitals. It's really critical that frontline staff are leading and involved in this work. It can't be the manager who's leading this, because then it becomes the manager's meeting and not the staff's meeting. We want you to build really strong partnerships. So build partnerships with your hospital quality and safety leaders, infection prevention staff, nurse educators, physician leaders. They're all members of our CUSP teams. We want to make sure the most successful, we know from studying them that the most successful CUSP teams are engaged frontline clinicians who take ownership of patient safety in their unit. And that was what was so rewarding to me when I started at CUSP in 2002. It was safety wasn't my Department of Patient Safety's problem, it was my problem, and I got to own that locally, and that was really exciting for me. It includes staff members who have different levels of experience, and it represents all stakeholders by bringing multiple groups and multiple disciplines together. We also know successful CUSP teams meet regularly. They hold at least 80% of their scheduled meetings, because if you cancel safety meetings in your unit, what message does that send to your frontline staff? That safety is not important here, right? So we know the most successful teams don't cancel their meetings. They have adequate resources, including some protected time for their frontline staff to do the work. So typically a champion might get 2 to 4 hours per week of protected time. They share leadership and they work together to make decisions. And the senior executive has a critical role here. I went over it earlier, but I'm just reiterating. They attend the monthly meetings, they're not on their phones, they're very engaged, and they help remove the barriers, but they don't lead the safety work. So we know, kind of in summary, that the best way forward for this technical and adaptive challenges that we have in order to eliminate preventable harm in healthcare is informed by science, right? And it's informed by science both on the technical as well as the adaptive piece. It's guided by valid measures that are both local and national, and it's led by staff and supported by senior leaders, because we need to build capacity. The only way we're gonna eliminate preventable harm in healthcare is by every individual in a hospital knowing their role in keeping our patients safe. And so that can't happen when it's just living with the senior leaders. It's gotta live with everybody. So with that, I'll end. Thank you. And hopefully we'll take questions.
Thank you, Melinda Sawyer. Muito obrigada, diretora assistente de segurança do paciente no Instituto Armstrong e também no Hospital John Hopkins. Bom, conforme anunciado, nós teremos uns minutos finais para perguntas de vocês e a mediação. Bem-vinda ao palco, enfermeira Vânia Rezig, superintendente assistencial do Hospital Moinhos de Evento. Perguntas, por gentileza, por escrito, encaminhadas através da nossa equipe que está circulando no corredor e nas laterais. Vânia, com você.
Boa tarde. Quero parabenizar a Melinda pela excelente explanação, demonstrando para nós o quanto que é importante o envolvimento de todos, né, desde a alta direção até as pessoas que estão, sim, lá na ponta, nos processos de qualidade e segurança, que é inquestionável a ida, né, de todos os membros da equipe da alta direção também ao chão de fábrica para entender os processos, para poder realmente fazer melhorias sustentáveis. Então, acho que a gente teve um excelente exemplo e uma excelente ferramenta, né, os CUSPs como ferramentas para melhorar a qualidade, a segurança, e o impacto das CUSPs realmente é surpreendente. Então, quero realmente parabenizar pela excelente explanação e dizer que a gente fica muito feliz em ver que temos, sim, como melhorar, né, nossos resultados em relação à qualidade e segurança dos nossos pacientes. Nós já recebemos a primeira pergunta, então eu vou fazer a pergunta aqui, que é em relação ao engajamento dos médicos. Quais as estratégias que são usadas para a adesão dos médicos aos protocolos e a participação dos núcleos de segurança de paciente, ou seja, das pessoas que hoje coordenam qualidade e segurança dentro da Hopkins?
Sure. Yeah, thank you. Great question. Something we continue to struggle with, so we don't have this problem solved. We engage physicians at all levels of the organization. So for our CUSP teams, every CUSP team has a physician champion, and in many areas, CUSP is led by a physician. So for example, in our operating rooms, the physician, including the surgeon and the anesthesiologist, are critical roles in that space. And so our CUSP teams in those areas are led by a nurse, a surgeon, and an anesthesiologist. And when you have local surgeons and anesthesiologists and physicians leading it, they can engage other physicians, and that tends to get other physicians engaged, because it becomes, oh, that's the team that can help me with my safety problem. And so they start to go to that team. In addition, we see physicians are leading CUSP teams in ambulatory, because without a doubt, the ambulatory care is driven by physician practice. And so as an example, one of our ambulatory teams has 85% of all of their physicians attend every single CUSP meeting, because those physicians, they're working on the very projects that the physicians are frustrated with, right? That makes the work hard. So they tackle, how can we make everybody in the clinic focused on mammography screening, on colon cancer screening, on blood pressure control. So these are the things that physicians want to improve for their patients, and so they're motivated to participate because they see the great work that's coming out of these teams. And so that's one example. But I think we also have to recognize that when we're working in these teams, we can't just work on projects that are important to nursing or to infection control. We have to engage our physicians to say, what are your biggest challenges? What are your biggest defects? And let's all together tackle those too. And so I think by that multidisciplinary approach, where anybody's problem is everybody's problem, then we see lots of physician engagement. I will say that we recognize that we have underinvested in physicians leading quality and safety, at least in our own organization, and we see that in the United States. And so one of the things we're doing differently, as of about 2 years ago now, is in every department in our hospital, we have a vice chair for quality and safety who's a physician, partnered with a departmental safety officer, which is a nurse, and the two of them are held accountable to the quality and safety performance of their department, rather than it just being a nurse. And so that teamwork has been amazing. We've had to help our physicians get more knowledgeable about improvement work, because in the United States it wasn't part of their medical school training. And so we had to get them trained up, and then now we're starting to teach quality safety across our pharmacy schools, our nursing schools, and our medical schools, and they learn together.
Muito obrigada. Tem mais várias perguntas aqui, ou seja, realmente a palestra da Melinda acabou realmente causando bastante impacto. Então, essa pergunta é bem a respeito da formação dos times para CUSP. Então, quantas pessoas usualmente compõem os times de CUSPs? Se essas pessoas são separadas como uma função exclusiva, trabalhar nos times de CUSP, ou realmente faz parte do trabalho delas, além da função que elas executam? E também como é formado, então, quais os profissionais que estão envolvidos nos times?
Great. So all of our CUSP teams, they all have an identified champion, and then also if that champion is not a physician, there's also a physician champion who's selected. And many of our CUSP teams will have actually now 2 champions and a physician champion, or if a physician's not one of those, just to have good backup behavior. So if one person goes out on medical leave, there's another person who's ready to step in and lead the CUSP team. They're selected not necessarily because they're the most senior person in their unit. It's the person in that clinical area who has the most passion for patient safety, who's really driven. And we try very hard to give them a little bit of protected time to do the work in addition to their clinical work, but they all are clinical work leaders in their local units who might be given a little bit of time to work on CUSP. And then I think the next question was, how are they trained? And so we have a very robust, again, CUSP program in our health system. We have 156 teams. And so we are constantly launching new teams, but then the champions are turning over, with some regularity, a predicted amount. And so we offer CUSP workshop training to all of our champions in our health system, and that's 3 parts to that training. There are online modules, which they take, it's about 8 hours of online modules. Then they come in for a 1-day simulation, and they simulate their first year of leading a CUSP team. So we simulate leading a quality improvement project, and they do that in a single day. It's really fun. It's a little bit stressful because it's really kind of fast work, but overwhelmingly they love it. But we also recognize learning doesn't just happen in the classroom. That learning happens when they're out doing the work. And so we have calls with all the champions every 6 weeks, and they call in to someone like me or another CUSP expert, and they can talk about barriers, and it's kind of like just a check-in to say, what are you focused on? What are your barriers? How can we help you overcome them? Because there will be barriers that they face that we didn't get to in the CUSP workshop, and we want to help them and support them through learning to manage through those barriers.
Obrigada. Temos uma outra pergunta que traz inclusive uma reflexão, que a Melinda usou aqui termos que vêm realmente da questão de Lean Six Sigma, como Gemba e outros termos. E também nos trouxe a questão do engajamento, que tudo inicia com o engajamento dos profissionais. Então, como vocês fazem com que ocorra esse engajamento dos profissionais para realmente fazer a mudança?
So how to engage healthcare workers? So that's not necessarily easy to do, but I think one of the things we tap into for frontline staff is frontline staff want to provide the best care for their patients. And they get frustrated with inefficiencies, with waste in the system, with being asked to do things that they don't feel make sense for their overall quality of their patients. And so we can tap into that frustration and engage them to work on these teams to try to improve care. Because again, this isn't me telling you how to improve care, it's me creating a structure as the safety leader, but creating a structure for you and your colleagues to get together so you can drive care and eliminate waste. And a lot of people, a big question I get, I thought this was what you were going to ask me, was how you have CUSP and you have Lean and you have team steps, and how do those all work together? Or aren't they just all these different projects? And we actually think they're all very synergistic. So CUSP for us is the structure at the unit level to create a space to do the work. And depending on the defect or the project, you might use a lean approach, or you might use a team steps approach, or you might use a learning from defect approach. And the more methodologies our local champions have, the more effective they can be at driving performance, because they can pull on a lean tool if they need to, or they can pull on their team steps master training if they need to.
Obrigada. Temos mais 5 perguntas aqui, acho que não vamos conseguir fazer todas devido ao tempo, mas consigo fazer mais uma, então, e depois, quem quiser, a gente pode conversar aqui pessoalmente. Uma pergunta sobre a cultura de segurança, né? A pergunta que a pessoa faz é: qual o questionário estruturado que é utilizado na Johns Hopkins para fazer a medição da cultura de segurança, e a partir dessa medição de cultura de segurança, qual o próximo nível que vocês estão buscando como desafio?
Yeah, so that answer is not an easy answer. We historically, for 10 years, have used the Safety Attitudes Questionnaire because the faculty member who created that was part of our Armstrong Institute. And we were just very experienced with that tool. We were some of the test hospitals to help them create and validate that tool. So we were very comfortable with that tool. But what we soon realized when we looked at the other valid tools, like the Hospital Survey of Patient Safety, the HSOPS tool from the Agency for Healthcare Research and Quality, was that there were critical domains that those tools had that weren't really included in the Safety Attitudes Questionnaire. So for example, teamwork across units. And so although safety culture of the SAQ was very much looking at unit culture, we recognized as an organization that we had issues that we needed to work on across units. So as a high reliability, or as an organization who's trying to become more highly reliable, it's called heedful interrelations. So how is it that I work with the teams that I get patients from, and how is it that I work with the teams that I send patients to? And how do we all work together? And so about 4 years ago, we started using a hybrid of both those tools. So we kind of picked the best from both tools. And then we've even gone another step forward, which was now, because the Hospital Survey of Patient Safety offers so many versions, like ambulatory and inpatient and ambulatory surgery centers, we now allow all the areas to select which version of the tool that they want to do, because really what matters is, do the results, are they meaningful for them? And if an ambulatory unit does not feel like the inpatient tool works for them, then they're not going to drive performance on it. And so we now have 5 versions of the tool, and we use a combination of both valid surveys. But I would say that's something we've evolved to and not something we started with. So what's really kind of on the horizon for us is a couple things. One, driving performance on safety culture in ambulatory. I feel like ambulatory is probably 10 years behind the inpatient world for safety and safety culture. So that's big on our radar for the past year or two. The other thing we're doing is we're starting a new version of CUSP called CUSP Cross Teams, where we get multiple CUSP teams along a particular, what we call patient highway. So in the surgical world, that's like the surgical clinic, OR, surgical ICU, surgical floor, surgical clinic, that highway of patients. We bring all those CUSP teams together once a month and let them work on cross-team issues to kind of tackle that. And then the other things we're working on, very much on, are the non-rate, what we call non-rate-based preventable harm. So the rate-based preventable harm are those things that we can measure really easily, like the quality measures, but there's other stuff that we can't measure easily, and as a result, we are at risk to ignore them. And so we're starting a whole committee work on the non-rate-based preventable harm things, and that's something we'll probably be growing for the next 5 years.
Então, muito obrigada, Melinda. Quero realmente agradecer de novo a excelente explanação, o quanto que também nos motiva para a gente poder trazer isso para o Brasil, porque isso é bastante novo aqui ainda, né? São ferramentas que a gente quer trazer, e no Hospital Moinhos de Vento a gente está com o programa já alinhado e vamos começar, então estamos bastante felizes por também estar aprendendo e poder fazer isso junto com a Hopkins e realmente motivar todos vocês também para a gente poder cada vez mais trabalhar a prevenção do erro, que é o que nós realmente buscamos fazer. Muito obrigada.
Obrigada, Melinda. Vânia também obrigada. E a sugestão da Vânia é excelente. Nós vamos ter tempo. Hoje o coffee não é break, é coffee de encerramento. Então teremos um tempo de interagir com os nossos convidados, nacionais, internacionais, no coffee a partir das 17h30. Quem precisar um cafezinho, uma água, lembramos que temos ali no fundo da sala. Bom, recados bem importantes. Atenção, gestores da saúde, gestores da área da saúde, amanhã pela manhã, às 9 horas, nós teremos uma reunião paralela à programação aqui neste auditório, uma reunião paralela específica aos gestores da saúde. Combinado? Então, fiquem atentos, será na sala Cambará, aqui neste prédio, já informo qual o andar da sala Cambará. Esse recado é para os gestores da saúde. Então, o coffee de encerramento eu falava antes, aqui embaixo, às 17h30. Não esqueçam que é possível, no coffee, conhecer um pouco mais do trabalho daqueles hospitais que fazem parte do programa Paciente Seguro. Os pôsteres dos trabalhos estão ali no Salão Imperatriz, Salão do Coffee.